So the Phoenix trial is based on the idea that BTK inhibitor Ibrutinib has preferential activity in patients with the ABC or non-GCB type of diffuse large B-cell lymphoma. This was based on a relatively small phase 2 trial that showed that, as I said, about 40% response rate in the ABC subtype compared to only 5% GCB subtype. So after we did a phase 1 trial looking at safety of the R-CHOP plus Ibrutinib, a quick randomized phase 3 trial comparing R-CHOP with Ibrutinib with R-CHOP plus placebo, and look what's the outcome. But in patients who had a non-GCB and a subset who had the ABC subtype. So this is a pre-selected patient population, not all comers. So in a nutshell, the primary endpoint, which is event-free survival, was not met, unfortunately. They were exactly the same. But it turned out to be for a reason. Based on a pre-specified subset analysis, it turned out that there's interaction between the treatment and age. Patients who are younger than 60 years of age actually did very well. There was a 12% difference in overall survival favoring the Ibrutinib R-CHOP arm. The older patients, unfortunately, did not tolerate the treatment well, so there was more death on that fragment of patients who are older, and therefore the net outcome actually canceled each other. So the older patients did not do well, the younger patient did better, but if you look at the general population, the outcome was the same. The subset analysis, although nobody likes subset analysis, was actually a sizable number of patients, 350 patients out of 880. So 40% of the patients were this subset who are less than 60 years of age. And as I said, a 12% difference in overall survival. We've never seen this before with anything that beat R-CHOP over almost 20 years. Question, what do you do with that, right? So this is not going to be approved by regulatory agencies for sure, because subset analysis. Question one can ask, I mean, it's, definitely we have to repeat the experiment one way or the other with, one BTK plus R-CHOP, and there's different talks about making some change in design, add antibiotics, prophylaxis, blah, 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 and so forth. But the question that you raise, I mean, should patients wait until the second randomized trial is completed, which may take 5-7 years, or should we use the current data showing survival advantage and make use of it?